Hi, I'm Jacob Moalim. I'm an endocrine surgeon here at Strong, on faculty both in medicine and in surgery. So patients are routinely referred to me for consideration of adrenalectomy for a variety of reasons. Probably the most common is a adrenal tumor is found incidentally on a CT scan that is done for any other reason, either of the chest or of the abdomen. Other common reasons include hormonal excess states coming from the adrenal gland, like a pheochromocytoma or a Cushing's tumor. We're finding more and more patients with primary aldosteronism or a Conn's tumor causing hypertension. And in some selected cases, patients with other malignancies like lung cancer who have an isolated tumor metastasis to the adrenal gland are also candidates for resection. So the procedure that I recently brought to Strong is a retroperitoneoscopic adrenalectomy, which still involves some of the similar laparoscopic techniques, but is fundamentally different from the typical laparoscopic adrenalectomy. Just to be a little bit more specific about the advantages, a traditional laparoscopic adrenalectomy, depending on the side that's involved, the right or the left, involves entry into the abdominal cavity and then extensive mobilization of either the liver and the bowel on the right or of the spleen, pancreas, colon, small intestine, and stomach on the left. All of this mobilization is very time-consuming and involves its own inherent risks to those intra-abdominal structures and is often much more difficult in patients who have had prior abdominal surgery, which these days is increasingly common. The retroperitoneal approach has the main advantage that by going directly into the patient's retroperitoneum, the adrenal gland, rather than being the last organ that's encountered, is usually the first organ that's encountered. And so this cuts down on the amount of dissection and operating that the patient is subjected to get the same result, which is a safe removal of the adrenal gland. So this is a typical cross-sectional image through a patient's abdomen at the level of the kidneys and adrenal glands, and the adrenal glands are visualized here and here. And as you can see, to get to this adrenal gland through the front, the typical approach for a laparoscopic adrenalectomy involves mobilizing all of these structures here, which are, in this image, the spleen, the stomach, and the pancreas. And if you think about this three-dimensionally, the patient's bowel would also be in the way. So all of these structures need to be rolled. In fact, the patient would be laying in a position like this, so that these structures can more easily be rolled this direction away from the adrenal gland, which, sitting on top of the kidney, would be the last structure that would be encountered. In the retroperitoneoscopic adrenalectomy, the patient would be laying this direction so that the port sites would be here, here, and here. The major advantage, I think, is that during retroperitoneoscopic adrenalectomy, the abdominal cavity is never entered at all. And so, as a result of this, patients have much less postoperative pain. Many of my patients have not required any narcotic medication after surgery. They usually will go home on the first postoperative day, which is similar to the laparoscopic adrenalectomy. However, their pain is much decreased, their return to work is much faster, and their disability overall after this operation is dramatically reduced. Again, because there's almost no handling of the intra-abdominal organs at all during the retroperitoneoscopic adrenalectomy. So this approach, while being so advantageous to the patient, is technically much more challenging. And the main reason for that is because the patient is in the prone position and because the operation is done entirely within the retroperitoneum, the patient's anatomy is 180 degrees in reverse from what us as surgeons are typically trained to do. There are very few prone position retroperitoneal operations that are done in surgery as a whole. And so this is counterintuitive for any surgeon who is attempting to do this operation without specialty training. The reason I went to Germany to learn this operation is Professor Waltz is the person who pioneered this technique, and he has very extensive experience with this operation now, totaling more than 1,000 cases. And so if there's any person to learn this procedure from, it's definitely Professor Waltz.